Hi. You had a different name, I think, like a nickname maybe?
Leah, Prof. Leah.
Leah. Okay. I remember, yes. You were on the cardiac rotation when I was visiting. Yeah.
Yeah.
Nice to see you again.
Nice to meet you. Okay.
Okay, so I think we can
Yes, I
start.
will give the host um, privileges over to Dr. Rizkya. Hmm. It doesn't. One second. I don't know why I'm not. Co-host. Oh, you are already co-host. So you go ahead. Yeah. Dr. Pinkan did the thing, I think, already.
Okay. Start. Okay. Good evening, Prof. Surányi, Dr. Amal, Dr. Aryugi, fellow doctors and resident. I'm Rizkya Amelia. Today, I want to bring the case for chest wall anomalies for today's PRODIGEE. So here's the case. A child S, female, 12 years. Main reason, absent right breast. A lump on the right chest wall has been present noticed since the age of 3 months. The lump protrudes during inspiration and recedes during expiration. This complaint is also accompanied by a concave appearance of right chest wall. The patient experiences pain when coughing. For history of present illness, the patient was born without the right breast and no medical evaluation was performed at birth for this condition. At the age 1 year, the patient was referred for ultrasound, which revealed a genesis of right breast. The patient was advised to return for re-evaluation at an older age. The patient developed a cough and was treated by pediatricians. Subsequently, the patient was referred to plastic surgery for the management of right breast agenesis. For history of past illness, the patient has a history of pulmonary tuberculosis at the age of 1 year, was treated with ATT for 6 months, and was declared cured. And here's for the imaging of the patient. Okay, here's for the conventional X-ray. We can see in the conventional X-ray a deformity of the right posterior rib. We can also observe that the upper right lung volume is significantly smaller than the left. However, overall, there are no other abnormalities visible on this conventional X-ray. We'll go to the CT scan of the patient. Here's for the CT, chest CT of the patient. Okay, let me start. We can see the right and left hemithorax walls appear asymmetric. And we can see here the right pectoralis major muscle shows hypoplasia. This one with the origin only at the sternum and insertion of the pectoralis right muscle at the humerus. And we also can see here the right pectoralis minor muscle isn't visible, suggesting aplasia of right pectoralis minor muscle. And then we can see here, we can see the right breast structures. This is the left breast structures, but there is no visible right breast structures. And then we're going to here, we can see there is hypoplasia of right anterior third rib. Overall, the heart structures and vascular structures within normal limits. We can see the subclavian artery here and the thoracic interna of the artery of the patient. We can see here is within the normal limits. We can see to the reconstruction of the 3D of the patient. Okay. Here's we can see the hypoplasia of right anterior third rib. There's aplasia of minor muscle right pectoralis major. And then we can see here there is no breast fractures on the right side. Okay. So these anomalies, as I said before, there's a hypoplasia of the anterior third rib, and then hypoplasia of right pectoralis major. There's no right breast structures, suggesting this is the Poland syndrome. what we need to know about the Poland syndrome, for radiologists, we need to observe which muscle are involved, what is their extent, is it hypoplasia or aplasia, how far do they extend, is the breast developed, is there any bone dysplasia because Poland syndrome may have a syndactyly, is there any vascular abnormality, such as arterial hypoplasia or agenesis, because some Poland syndrome patients have shown hypoplasia or absence of the subclavian artery, axillary artery, or brachial artery on the affected sites. So it can reduce blood flow or anomalous blood flow to the chest wall and upper limb. So it must be observed from radiology. So this is from me. Maybe any feedback and suggestion from Professor or doctors. Thank you.
Very nice presentation. Very interesting case. Thank you so much. If you could please go back to the MPR, the multiplanar reformats, and follow that subclavian, maybe on the coronal view. That was a little bit too fast for me.
Oh,
I wanted to see that again. Just on the coronal, yeah, on that coronal view, just to see, but okay. So they're all in place. Yeah, so there's nothing, I missed that part. Okay, very cool. And then you can see that hypoplastic rib on that view as well, very nicely. Does anybody else have any questions or comments?
I want to confirm something. You said that there's movement at the lump in the clinical.
yes, doctor.
Does it look like paradoxical movement like we found in flail chase, you mean?
He said when expiration and inspiration, there's a lump. Maybe it's because the hypoplasia of the anterior rib. Pardon, maybe.
Yeah, because we saw like from the VR, actually there's empty space that there's no bone in there. So I think yeah, so I see that maybe the movement actually will look like the paradoxical movement like when we saw in patient with flail chest. I don't know,
Yeah,
it's only in my
yeah.
mind.
No, it's very excellent thought. I think that's spot on. Yeah, you're probably very right about that. Yeah, because there's the cartilage too. You can see the cartilage medially, right? But it's not as long as the other side. If you look at if you window it a little bit differently, you can decrease some of the other soft tissues and accentuate the cartilage, yeah, and the bone. And you see that also a piece of the cartilage is missing. So I think Dr. Yogi is correct about that. Very interesting. And then just so for everybody's edification, would you repeat the list of associated abnormalities? Because it seems like this is a spectrum, right? So like the expression of the disease or the syndrome is variable. So what are the potential things that are missing or hypoplastic in these patients? You had just a very nice list. If you could just repeat that.
First, we must see which muscle are involved. Especially in Poland syndrome, there is a hypoplasia or aplasia of right pectoralis major muscles, and then there's no breast structures develop on the affected side, and then bone, bone dysplasia such as syndactyly, and then vascular abnormality that we must observe, like as I said before, hypoplasia of the subclavian artery. Some of Poland syndrome patients have shown of hypoplasia in subclavian artery. And then I think there's all that we must observe for Poland syndrome, Prof.
Okay. All right, very good. Anybody else have any other questions? No questions? Okay. Then I think I will try to share my screen. And thank you so much, Dr. Rizkya. That
Thank
was
you, Prof.
awesome. Thank you. So I chose to show some cases to you all that where patients have some sort of chest wall deformity or abnormality, but there is also some sort of effect or some questionable effect on the cardiovascular system as well. So we're going to start. I'm just folding things up. We're going to start with this patient who, as you can see on the scout, this is actually an adult patient now, 28 years old, a female patient. You can see that they have history of scoliosis, which was fixed partly or corrected. But any time you see patients with chest wall deformities or significant scoliosis, you should think about the fact that maybe this patient has some sort of connective tissue disorder. Like one of those is Marfan disease, for example, but there are other connective tissue diseases like Ehlers-Danlos syndrome or Loeys-Dietz. And a lot of these patients have connective tissue abnormalities in various organs. So that manifests in the musculoskeletal system, but also can manifest in the aortic wall. So a lot of these patients will develop aneurysmal change and all the consequences thereof, and also in the valves in the heart. So a lot of these patients will have mitral valve prolapse, for example, or aortic regurgitation as their aortic root dilates and the leaflets don't coapt properly anymore. So this particular 23-year-old, as you can see here on this cardiac scan, if we scroll through, obviously we have some artifact from the spinal hardware. But as we scroll through to the left atrium, we see this dilated aortic root. And then as we get to the level of the mitral valve, already on the axial view, it becomes obvious that this patient has significant prolapse of the posterior leaflet. But the best way to assess this is going to be obviously on a multiplanar reformat. And also very important to remember that when you're evaluating, for example, for mitral valve prolapse, you have to be ideally at end systole of the cardiac cycle or sometime during systole when the mitral valve leaflets are closed and are bulging upwards toward the atrium. Now, on the axial view, it's sometimes missed or more commonly missed, I would say, but I would argue that it's very important, therefore, to identify the anatomic landmarks even on the axial view, such as the attachment points of the mitral valve leaflets, that is the mitral annulus. So laterally, you can see where the lateral basal myocardium ends. This is going to be one anatomic landmark right here. And then on the other side, you will have the point where the mitral valve anterior leaflet joins the aortic valve leaflet. So these are the two anatomic landmarks where the posterior leaflet joins the lateral wall, where the anterior leaflet joins the aortic valve. And you could actually draw a line across like this, and this is going to be your anatomic level from which you would have to measure the distance of the prolapse. Now, I understand that it's not a proper measurement in the axial view, so I'm not going to put a measurement on it in this view, but just mentally, as you're scrolling through these patients' studies, that's how you would identify if there's any suggestion of mitral valve prolapse. And then, of course, you would go into a multiplanar reformat, like so. You put your center of rotation somewhere in the center of the mitral valve. then you see on your two-chamber view, you confirm that that is also in this dimension central in the mitral valve orifice. Then you angle it so you're lining up with the apex of the left ventricle as much as possible in both of these views. And then you can spin your axis around, with the central axis being in the mitral orifice. And as you spin it around, you can fully examine the mitral valve, all its portions. We previously discussed that the mitral valve has two leaflets, and each of the leaflets have three scallops, A1, 2, 3, and P1, 2, 3. And sometimes there's isolated prolapse of certain leaflets, whereas others are relatively normal. Again, here our anatomic landmarks are going to be the point where the mitral and aortic annulus meet, right here, and laterally, again, where the myocardium stops. So here, now we can actually draw a line and get an actual measurement of the prolapse. Some people give about a 3 millimeter leeway that's accepted as normal. We have 20 millimeters of prolapse in this case. Also, while we're at it, just discuss the measurement of the aortic root. The correct measurement of the aortic root is going to depend on the abnormality that you see. In patients where the aortic root has a radial symmetry, like in this case, you will measure sinus to commissure. Where two leaflets meet, that's called a commissure. And obviously, the three sinuses of Valsalva, if they're present, that's how you will measure. And you will measure it 3 times and take the average of these 3 measurements. So sinus to commissure. Some people advocate for maximal diameter sinus to sinus, but it's really just be consistent when you're following up cases. That's the most important thing. And I will actually say that the American Heart Association guidelines with patients that have bicuspid valve actually would suggest that you should measure the root area. So if the patient also happens to have a bicuspid valve, you have to measure the area of the root or the cross-sectional area of the ascending aorta that's dilated and report that, because the cardiologist will divide that by the patient's height in meters, and that's going to be the important number for deciding whether or not the patient needs surgery and when they need the surgery. So here, strictly speaking, the chest wall deformity is kind of a adjacent finding, doesn't directly affect the cardiovascular structures, but I wanted to show this case nonetheless because it's very important for us cardiac imagers to identify these abnormalities, even if the CT is done for, let's say, checking the hardware of the scoliosis. Mitral valve prolapse is one of those diseases that leads to regurgitation, and that regurgitation can kill the left ventricle slowly. And by the time the patient is actually symptomatic, it may be too late to do anything about it. And these are fixable problems. Both the aorta can be replaced and a dissection or rupture can be prevented that way. And mitral valve can be repaired, sometimes with what we call a valvuloplasty, a surgical valvuloplasty, which does not necessitate the implantation of an artificial valve, just the correction of the shape of the leaflets, reattachment of some of the chordae tendinae, and perhaps putting in a mitral valve ring, an annuloplasty ring to approximate the annulus closer so the leaflets can coapt once again and prevent regurgitation, and thereby preventing the volume overload and over time the dilation of the left ventricle. So that would be the first case. Sticking with the theme of Marfan syndrome, this patient will actually have a chest wall deformity. This is a 36-year-old adult male patient. And I will start with the 3D, just like Dr. Rizkya did. 3D volume rendering is sometimes very helpful to look at the shape of the chest and identify abnormalities. This patient also has a funny lump or two in the front of their chest. And this chest wall abnormality is called pectus carinatum. Like the carina has this shape, right? So it sticks out. And instead of having a pectus excavatum, when it's caved in or excavated, the chest, in this case, the sternum sticks out anteriorly and causes this kind of a chest wall deformity where the patient has these outward bumps on the chest. This patient also had Marfan syndrome, like I mentioned, and we shall go and look at this heart a little bit closer up. And the astute observers already are probably observing that there's something really wrong with this mitral valve. Granted that there is some motion artifact as well. But even on the axial view, if we use the same anatomic landmarks right here and right over here, we can see that some of the leaflet portions are extending above this line. So we see that this patient also is going to have mitral valve prolapse. You also have some leaflet thickening and apparently some redundancy. And we have a fairly large left atrium. By the way, I forgot to mention that on the other case, but in patients like this, when you're trying to assess the size of the left atrium, you should be in the end or at the end diastolic phase, line up the patient's dedicated cardiac planes into a 4-chamber view. You see there is some misregistration. You want to make sure that you exclude the aortic root from this view, because if you include the aortic root, then you're dealing with a 5-chamber view. You have to make sure that you're not in the aortic root, but you've stretched out your left side of the heart properly and then rotate it so you are cutting through the widest point of the right heart, the widest point of the right ventricle over here. And you can all see that this patient definitely has a subjectively dilated left atrium. However, if you want to be more analytical and quantitative, you would measure the cross-sectional area of the left atrium. And in adults, usually we use a quick and dirty cutoff of 25 centimeters squared. So this patient has 53 centimeters squared. This is, the software gives it as in millimeters squared, but it's 100. Move 2 decimal points and you get your centimeter squared. So this is twice the upper limit of normal. So definitely, undoubtedly dilated left atrium. Another thing that to keep in mind, if you don't have a cardiac gated study and you don't have an end systolic phase, which is the proper time to measure this, you can only underestimate this. So if you have a random phase of the cardiac cycle and the left atrium by this measurement appears enlarged, it's definitely enlarged, because at end systole it would be bigger, because that's the time point when it's at its largest. So any other phases of the cardiac cycle, you're likely to underestimate it. So if your measurement already hits above 25 centimeters squared, it's very, very likely that it is enlarged. Another observation in this case, along the lines of loose connective tissues, is you can see this bulging of the interatrial septum. That would be called an interatrial septal aneurysm. And oftentimes these aneurysms are also mobile, so they might change their position in the cardiac cycle. And they're frequently associated with a patent foramen ovale. So that's another thing that I would mention in this case, and definitely see the prolapsing mitral valve leaflet portions in this view. And as we're turning around, you can see the thickening of these mitral valve leaflets, but also you can see that the prolapse is actually not readily observable on all the views. This is why it's very important to examine all of the scallops of the mitral valve to identify the portion that's actually prolapsing, because it might not be visible on all of the 2, 3, 4, 5 chamber views. Maybe it's only visible on the 2 chamber or maybe on the 4 chamber. Since the P2 is the most commonly involved, it's the 4 chamber and the 3 chamber that are going to be the most likely ones that show the abnormality. Let me see if I can show you some MR images on this patient. Yeah, and so here it is beautifully now in motion, that prolapsing mitral valve. We're slicing through the left side of the heart in the 2-chamber plane. I'm just scrolling through the whole heart, and we're going to go back to the best images to do our measurements. You can also see the appearance of a little jet, centrally bright, peripherally dark. You can see that this patient has mitral regurgitation. Again, we're cutting through the jet. The jet is probably eccentric, so it's not shooting exactly in the plane of our image, which is why we see a circle, a bright circle with a dark circle around it. It's because the jet is kind of off out of our plane, and we're just cutting through the jet. A lot of the times when you have mitral valve prolapse, because the 2 leaflets not equally prolapse, one of them prolapses more than the other, you'll get these eccentric jets. Whereas if the reason for mitral valve regurgitation is simply the dilation of the annulus and the incomplete coaptation, then you usually get a more central jet shooting straight backwards to the back of the left atrium. In this case, you can clearly see that the jet is actually sort of an eccentric jet. In this view, notice that the mitral valve prolapse is most pronounced at the time point when the left ventricle is at its smallest, i.e. at end ventricular systole. And then our anatomic landmarks again, the hinge point of the valve right here, and the hinge point of the valve, right over here. So the measurement of the extent of prolapse would be from here to here. This is, in this patient, it's 10 millimeters. And like I said, it would be important to check this out in other views as well. So let's go into the 4-chamber view. We're going to scroll down slowly. This is the level of the pulmonary artery. We're getting into the aortic valve. Notice that in this view, it almost looks like there's nothing wrong with the mitral valve. Same patient, same day, same MR examination. Very important to look through all of the images carefully. And in this particular view, you can start to see the jet. The jet is actually shooting in this direction. Quite strange. There it is. And then, so this could be a jet that's kind of hiding, because then it'll bounce off of the septum and cause the turbulence back here. So it's very interesting jet in that sense. And here you have to go all the way to the bottom of your 4-chamber image view to appreciate the prolapsing portion of the valve. So very important to carefully examine all of our images in these patients. And I think that's where we're going to stop in this case. I don't think there's anything else that's super interesting. All right. The next patient, well, we'll stick with Marfan syndrome for one more case, just so you guys can see this. I think I wanted to focus on just reminding you of one thing in patients with Marfan syndrome. Again, this patient has a history of scoliosis, a little sort of a bump in the anterior chest wall. You can see, so this would be, again, pectus carinatum, where the anterior portion of the chest wall sticks out. You can see on the end, the axial view very nicely. The patient has already had a median sternotomy, but this is not from that. This is just because of their Marfan syndrome, pectus carinatum, and scoliosis, which has been repaired. And certainly you can already see that there's a mechanical aortic valve in this patient. So the patient already had their aortic valve replaced. I don't remember exactly what the reason was, whether it was a bicuspid valve or just a very dilated aortic root, and therefore the aortic valve was very regurgitant. But certainly the patient has significant chest wall deformity, and the surgeons replaced this patient's aortic valve. And so this portion, what you see here, is actually a graft. These portions are the reimplanted coronaries into the graft, which are called the coronary buttons. When they remove the native coronaries from the native sick dilated aorta that has the connective tissue disease, they take a little bit of a rim of the aorta with the coronaries, that's called the coronary buttons, and then they reimplant that back into the graft. Now the graft is synthetic material that's not going to dilate, but the little rim of the aortic tissue, the native aortic tissue that still has the Marfan disease, that's going to keep dilating under the pressure, under the systemic pressure. So often you end up with this appearance where you have dilated coronary buttons and these areas are aneurysmal. And it's almost an expected appearance after repair of the aneurysmal aortic root and ascending aorta in these patients. You can also often see calcifications of the graft itself because it's foreign material, so that's not atherosclerosis. Another important thing to remember that grafts, well, not only do they not grow, but they also cannot dissect. So if something looks like it's a dissection, after the aorta has been replaced in that segment, it's probably a pseudoaneurysm next to the aorta and not a dissection. So that's actually very important to keep in mind. I'm going to show you from a different view. Here you can see the mechanical valve. Here you can see the artificial graft. And you can see this aneurysmal coronary button. Both of the coronary buttons here. That's for the right coronary, and this one is for the left coronary. And, well, let's see. I can show you in 3D. We looked at the chest wall deformity already, but I'm going to show you the coronary buttons in this view. So this is your right coronary button. the dilated area, and the left coronary button is hiding in there. But you can see it in here. You can see the two coronaries. That's the LAD. This is the circumflex, and the coronary button is in there. But if you don't believe me, I'm going to try to create a clip box. Hopefully now you can see. There's your coronary button here. All right. And of course, I cannot reiterate enough times that these patients often have mitral prolapse. And you guys are saying, like, this is very boring. He keeps showing us the same thing. Well, that's partly true. And 1 second. There's a beautiful example of mitral valve prolapse. Again, if you use your anatomic landmarks at the shoulder of the myocardium here, and you measure from that distance the extent of prolapse. Another thing that's kind of, while we're at it, that we might want to just quickly touch on is mitral annular disjunction. Some of the patients with mitral valve prolapse also have a gap here between the actual myocardium and the actual attachment, the actual fibrous annulus. Now, we have to be careful with this for two reasons. Some of the cardiologists don't like this diagnosis, and it's kind of a debated diagnosis, so we need to be aware of that. And there are pitfalls also, because if the leaflet, the annulus is actually here and the leaflet just bulges out, it can give us this appearance where there is mitral annular disjunction. So it's important to look at the leaflets during systole 2 carefully, whether they are actually starting here with the disjunction, or they're just starting here as they should, and then they actually just, it's a pseudo mitral annular disjunction. Nonetheless, I think all radiologists should be aware of this entity, because it's thought, there are lots of papers on this, but it's thought to be associated with malignant ventricular arrhythmias, actually. It's interesting that this connective tissue disconnection somehow has an association with very bad ventricular tachycardias and ventricular fibrillation, so sudden cardiac death. So if I see it, and if I'm confident, then I will mention it. If I'm not confident, then I will mention that this may represent mitral annular disjunction, and then the cardiologist can do with it what they want, which would mean either a transesophageal echo and a closer observation, and they can decide for themselves. And the last case I wanted to show you I'm pretty sure that I show you the first image, and you will know what I'm trying to show you. A lot of you. If I show you this image, a lot of you already will say, oh yes, we're talking about pectus excavatum, right? You can see the marked AP narrowing of this chest. You can always calculate the Haller index, which is like the ratio of the biggest width of the chest to the smallest width. And pectus excavatum is sometimes it's probably underdiagnosed in terms of its cardiovascular effects. Obviously, it's a very visible abnormality, and a lot of people live with it, and a lot of people have no problems with it. But in some cases, the compression on the heart and the cardiac chambers may lead to cardiac dysfunction. Among those is cardiac arrhythmias, not just atrial arrhythmias like atrial fibrillation, but also ventricular arrhythmias and even sudden death. So it's not a negligible thing if somebody has pectus excavatum in terms of the cardiovascular implications. The other thing to keep in mind that pectus excavatum sometimes gets worse with age, with time, even in adulthood. Not everybody, but I have seen cases where the pectus deformity gets more and more pronounced, and therefore the cardiac symptoms get more and more pronounced. So this was this patient I know for several years now, and the presentation, this is a very healthy 33-year-old female who's works out, eats healthy, leads a very healthy life, and has been noticing, so had no problems for 32 years. And all of a sudden started having abdominal pain. And the most extensive workup was done, and nothing really was found other than a very large IVC and sort of dilated hepatic veins and maybe some suggestion of hepatic congestion. So this patient underwent all these kinds of examinations, cardiac catheterizations, right heart catheterizations, and of course, a cardiac MRI as well. And the cardiac MRI was actually ordered with the question of, is there pericardial constriction? Because she had, on right heart catheterization, had all the symptoms of constrictive pericarditis. And of course, on echo, they didn't see anything wrong with the pericardium, but echo is not the best modality, nor is CT. So they've decided to order a cardiac MRI. And on the cardiac MRI, we scanned this heart up and down and really didn't see anything wrong with the pericardium or any portion of the heart other than this marked Haller or marked pectus excavatum, which clearly looks like it must have some effect on the function of the right ventricle. But if you look at the dedicated projections like this 3-chamber view, it looks like this heart is doing just fine. 4-chamber view, there doesn't seem to be any issues with the heart structurally per se. So we ended up doing some of the real-time images. To test for pericardial constriction. And this is real-time imaging, so super fast images that are being acquired as we are, or that are being reconstructed, and we can visualize them as soon as we are acquiring them. So there's no cardiac gating needed. They're just super fast images, and you get about 10 images per cardiac cycle, or 7, depending on the heart rate and your scanner speed. Here you can see that this anterior chest wall is impressing on the right ventricle. And as we're asking the patient to take a deep breath, which is the test of choice, you can actually see that you do have a little septal flattening transiently during deep inspiration. So during normal rest, you have a nice donut of the left ventricle, both at in the diastolic and the systolic phases. But as soon as the patient's diaphragm starts to move downwards, you will see that right there, there's a little flattening of the septum. So, which means that the filling pressures all of a sudden in the right heart exceed that of the left heart, just momentarily. And that's probably what the interventional cardiologist saw during their catheterization, that there are physiologic signs that mimic constriction. But obviously the patient's pericardium is completely normal. And then I thought that maybe we should look at this IVC as well. So we looked at the IVC during the deep inspiration as well with real time. I was really curious if maybe there's some obstruction here. Maybe there's a very prominent eustachian valve, which there is a prominent eustachian valve, but it doesn't seem to cause any flow obstruction significantly. It's a little bit narrower here, and this IVC does appear congested, but we were unable to identify the reason for the abnormality other than the pectus excavatum. I'm just trying to find the flow images that we did. We also, I believe, we also did some flow imaging on the IVC. We did a 1-year follow-up, by the way. We measured all kinds of volumetrics and ejection fraction and everything. And everything was very stable. And the extent of the pectus excavatum hadn't changed either. I might not be able to find those images for you, so. Yes, okay, so here we go. This is our phase contrast velocity mapping. So we're doing now in plane phase contrast velocity mapping. So if you think about it, I just want to pull up the anatomic image next to it so you guys can all see what we're trying to do here. So this is the view. This is our spine, anterior chest wall, liver, IVC. SVC is up here, and this is the right atrium, and this is our eustachian valve. Interatrial septum, and the left atrium over here. So this is the corresponding phase contrast velocity mapping. And you can see the aorta here, descending aorta, by the way, has very high velocities. Obviously, that's why there is some aliasing here. But I want to turn your attention to this portion in the IVC. It's exactly the area where we had this slight narrowing between the interatrial septum and the eustachian valve here. And you can actually appreciate that there is some acceleration here. So there is some hemodynamic narrowing here. And you can also see aliasing here, which means there are rather high velocities here. So it is possible that during, especially exercise, as this patient often exercises, that as the anterior post-AP compression is pronounced and with the way she's exerting herself, it is possible that there is some narrowing here at the IVC inflow that gives her basically the symptoms of hepatic congestion and abdominal pain and all that. So, but like I said, there's no pericardial problem. There's no structural heart disease per se. The only abnormality that we can see is a slightly prominent eustachian valve and the pectus excavatum. But this is how we evaluated this rather challenging case. And I'm not saying we found the abnormality conclusively, but we definitely tried. All right. So I'm going to open up for questions if you have any questions. Thank you for your attention. These are the chest wall cases that I had. And please feel free to ask also in the chat if you'd like to put in a question. I'm going to open up the chat box.
Prof, maybe I have one question.
Yes.
So that we're talking about the effect of the pectus excavatum to the correct associated condition with the intracardiac chamber, just like the MVP. My question is actually how the pectus excavatum impact to the extracardiac structures, just like the vessels.
I've not seen a case where that was a significant problem other than the proximity of the vessels, like the aorta is going to be often very close to it. And if the patient needs cardiac surgery for their mitral valve or their aortic replacement, it's a more tricky median sternotomy, right? And even after surgery, when they put the chest back together, it's more likely that you will have adhesions between the aorta and some of the other structures. Actually, I'll pull this up quickly. I'll share this. Excellent question, by the way. So, as you can imagine, the aorta here gets very close to this is now the manubrium because of the very diminished AP distance. But depending on the heart's location, it could be various vessels as well. But that's the only thing I can think of. Maybe somebody else online can add something to that. I've not seen a case where there was like a significant vascular compression, other than maybe like we just talked about the IVC and the inflow into the right ventricle. Does anybody else have any thoughts on that?
Actually, I have a case that it's not related to the vascular compression, but because of the AP diameter, it's narrow. The complication caused the trachea compress because trachea and the bronchus, because the diameter or the distance between the ascending and descending aorta, it's narrower also. So it's the case that I found I think 2 years ago.
Very cool. Great question. Any other questions?
Prof.
Okay, yeah, first.
I would like to confirm in the measurement of the mitral valve prolapse, do we need to only report the prolapse qualitatively or any objective measurement that we need to report for these findings?
Yes, I would, like I showed you, the measurement of the annulus level and the maximum prolapse of whichever leaflet that is, and that's also important to report if you can identify it's the anterior leaflet or the posterior leaflet or both leaflets, and measure it. I'm going to pull it up once more. One of these cases, I guess nearly all of them had prolapse, so it's not going to take too long to pull it up. You still see my screen, or do I need to? Yeah, you should still see my screen. Yeah. So the actual landmark is where the muscle stops here and where the other leaflet touches the muscle. So this is always going to be your landmark, and you draw a line this way, and then you measure from that level, you measure the topmost part of the valve leaflet, wherever that prolapse is. Does that make sense?
Yes, thank you, Prof.
Yeah, so that's the measurement, but because the valve prolapse might not be visible the same way in every view, you'll just pick the view where it's best visible. But you should pick one of the long axis views to get an accurate measurement. If you're measuring it just on an axial CT slice like this, you might not get an accurate measurement. So in a case like this, you would have to do the multiplanar reformat, not on the axial view, but do the multiplanar reformat. And then find the view where you can see the prolapse the best. Right? In this case, it's the 3-chamber view. And again, use your anatomic landmarks. So this is the hinge point of the mitral anterior leaflet where it meets the aortic root and the aortic leaflet. So that's the annulus here. And this is where the valve leaflet hinges onto the mitral, or onto the inferolateral basal myocardium. And then you would measure it like this. So that's kind of what I've been doing. So anybody else? And then, of course, if you have the ability to quantify your mitral regurgitation, then especially with MRI, then that's very helpful. That would be an important measure of how bad the effect of the prolapse is on the hemodynamics. And then the consequences of the mitral valve prolapse and the regurg would be left ventricular dilation. So the surgeons and the cardiologists will be watching the size, the end diastolic volume of the left ventricle, and of course the size of the left atrium. And then eventually, once the left atrium is very dilated, then you might end up with a atrial appendage thrombus. So you want to make sure that you exclude that. Those would be the important things to report in these patients. Excellent. Any other questions or comments? Announcements?
We have a question on the comments.
Yeah.
We have a question from Dr. Amelia in
Oh,
the
hey,
group
Dr.
chat.
Amelia. Yeah. How often do I see? I don't know if I know the exact percentage. I see probably more than my cardiologist would like me to see it. There's a lot of them don't, like I said, the cardiology world is a little bit divided on mitral annular disjunction. I just wanted to caution all of you with that. But I would say roughly one out of 5, I probably see something that looks like it may be. But again, I'm very careful the way I word it. So I'm very gentle with it. Like, this may represent mitral annular disjunction. Consider further evaluation with transesophageal echo. And then the cardiologist has the freedom to pursue that and say, okay, let's do that, or give me a call. We'll look at the images together. And then they get a transesophageal echo and decide. Or they might just say, yeah, I don't think so. And then they don't do anything about it. If they're really concerned that the patient has episodes of palpitation or something like that, then they can put the Holter monitor on the patient and see if they do have ventricular arrhythmias. So the practical management follow-up of measuring or mentioning mitral annular disjunction, in my mind, would be that the cardiologist would put a Holter monitor on the patient and see if they do have PVCs, do they have short ventricular tachycardia runs, and then they can pursue that if the patient has those high-risk ventricular arrhythmias. And then they can analyze the morphology of those. Good questions. All right, so thank you. You're welcome. Thank you, everybody, for joining us. Thank you, Dr. Rizkya, and for presenting, Leah, and Dr. Amal for mentoring and everybody's questions, Dr. Yogi. And we will go into our summer break. I wish a beautiful summer for everybody. And we will be announcing whenever we will resume. Not exactly sure, but just keep an eye out on in WhatsApp. We will have a workshop in July that's geared mostly towards technologists, but I think some of you might be able to join and sign up. I'm not sure about the exact logistics. Maybe Dr. Pinkan or Dr. Amal, you want to say something about that workshop?
Yeah, thank you, Prof. Yeah, I think we will have a workshop July 13th on Sunday. So it's 7:30 a.m. GMT +7. So will be evening in US. So it's the workshop is actually we will help for mainly for a radiographer or technologist, but everyone can come, especially radiologists that have interest in cardiac. So we will hold a workshop like how to scan the patient and about the protocol and everything from CT and then MRI, adult and pediatric also. And that's July 13th. So thank you so much.
Thank you, everybody. Hope to see you guys, if not at the workshop, but then in a couple months. Bye-bye.